Welcome to the HCMC training video for the use of ultrasound guidance during the reduction of closed distal radius fractures. There's never been a simple way for emergency medicine physicians to determine the adequacy of their distal radius manual reductions. We've either had to wait for a post-reduction x-ray and risk having to unsplint, resedate, and re-reduce the patient, or we use C-arm fluoroscopy during the procedure, which can be cumbersome, time-consuming, and adds additional cost and radiation exposure. During this video, we would like to introduce a new, quick, and inexpensive method for determining bony alignment and adequacy of your distal radius or Colles fracture reductions using ultrasound. By using the 7.5 megahertz rectangular ultrasound probe and placing it longitudinally along the dorsum of the distal radius with the marker dot pointing distally, one can clearly see a sagittal view of the bony elements of the wrist, similar to the view from a lateral x-ray. The depth or zoom function of the ultrasound machine may need to be adjusted to bring the image into view. As the probe lies over the radiocarpal joint, we can clearly see the articulation between the distal radius and the lunate bone of the wrist. The lunate is the bone on the right that moves as the wrist is flexed and extended, and the radius is the bone on the left. By sliding the probe proximally just a few centimeters, we can follow the dorsal cortex of the radius to the area of the fracture. The cortex is usually smooth along its entire length. There is often a visible bump near the end of the radius that is a normal variation, called Lister's tubercle. It can be distinguished from an abnormal finding because it will still have a smooth cortex with no disruptions. By moving the probe slightly more medially, this bump can usually be avoided. This is a view of a normal radius. The dorsal cortex is smooth along the entire course. When compared to the image of a fractured radius, it's easy to see the area of the fracture, which appears as a disruption of the cortex, or in this case, a complete dorsal angulation. After diagnosing a distal radius fracture by plain x-ray, you should attempt blind, closed, manual reduction in the usual fashion. When you feel that you have achieved reduction, and just before placing the splint, the ultrasound probe can be placed longitudinally on the radius to determine alignment. In this case, the reduction was felt to be adequate after blind reduction, but by using ultrasound, it was obvious that the distal segment of the radius was still dorsally displaced. The tick marks on the side of the screen are equal to 1 centimeter each, so even though this displacement is only by a couple millimeters, the visualization is dramatic. After one more reduction attempt, the alignment then appeared perfect. The dorsal cortex is now lined up along its entire course, and this correlated to a near-perfect alignment on post-reduction x-rays. In summary, ultrasound guidance can be used as a quick and easy way for determining the adequacy of a manual reduction of a distal radius or Colles fracture before placing the patient into a splint. By placing the probe longitudinally along the distal radius with the dot facing out and sliding it forward and backward, you can follow the contour of the bony cortex and visualize any displacement that might require further reduction. Remember, reduce your fractures like usual, check for displacement using the ultrasound, and reduce again if necessary, looking with the ultrasound after each reduction attempt. Everyone should take some time to practice with the ultrasound on their own wrist or a colleague's wrist before attempting to use it during a real reduction.